Great. Good morning, good afternoon, and good evening, everyone who has joined today. Let me start sharing my slides. And welcome to this IHEA seminar organized by the Special Interest Group for Financing for Universal Health Coverage. My name is Jacopo Gabbani. I'm an economist at the World Bank, and I will be starting with introductions. Just to check, can everyone hear me well? Great, thank you.
Loud and clear.
Thank you. Right, so today we will be talking about health insurance in low and middle income countries, learning from experience. Yeah, we are targeting to for this webinar to last for about until 11 a.m. Eastern time. This is the agenda for today. I'll be introducing the panelists in a minute. There will be a presentation from Reem, Hafez, Senior Economist, Health at the World Bank, on health insurance in low and middle income countries, a framework for evaluation. We will then have a discussion on the presentation itself, but also on a number of cogent and topical issues on the issue of health insurance in low and middle income countries. I will then take Q&A from the audience, which can be written down in the chat. I will be moderating the chat while Manon Hammerly, Economist, Health at the World Bank, will moderate the discussion with the panelists. So please write your questions in the chat. I might come back to you already in the chat, but otherwise, the questions will be taken during the last piece of Q&A from the audience. And finally, we will close by 11 a.m. Eastern time. Good. So let me introduce the panelists. We have four impressive panelists today, and we're glad to have this diversity in terms of we have multilateral development banks, we have government, we have university and NGOs represented on the panel today. First, Reem Hafez is a senior health economist at the World Bank. She has over 18 years of experience in international health policy, health financing, and health system reforms, combining analytics and implementation research. Her country experience include several countries. I'll name some of them: China, Nigeria, Sudan, Indonesia, and the Philippines. And today we'll actually have some experience from Indonesia with Dr. Hasbullah Tabrani, Professor Tabrani. Reem holds a PhD in health and a doctorate in health economics from Oxford University. Dr. Michael Amara is the Sierra Leone Social Health Insurance Team Lead. Sierra Leone Social Health Insurance, sometimes abbreviated in SLESHI, and is also the principal health economist at the Ministry of Health of Sierra Leone. He has more than 20 years experience in the health sector space, dealing with private and public domains, policy formulation, conceptualization, evaluation, and research. He has particular practical and theoretical skills in healthcare financing, including pioneering performance-based financing in Sierra Leone, and of course, leading the Sierra Leone Social Health Insurance team. We have Professor Tabrani, who is the Chief of Party for Think Well, the USAID health financing activity. He's also the chairman of Indonesia Health Economics Association and a professor at Universitas Indonesia. Dr. Tabrani has been working in the field of health economics for the last 3 decades in Indonesia, He's been instrumental in the development of the National Health Insurance Scheme, always or often abbreviated as JKN. He's been a senior health financing advisor in the National Social Security Council in Indonesia and oversight the body instrumental to the implementation of the JKN, which was designed based also on his work 15 years ago. He studied policy administration at UC Berkeley, and he has a wide network currently working for ThinkWell since September 2018. Finally, Professor Winnie Yip from Harvard, Professor of Global Health Policy and Economics, Professor of the Practice of Global Health Policy and Economics at the Harvard School of Public Health. Dr. Yip is a professor at Harvard Chan, serves also as the faculty director of the school-wide China Health Partnership, and recently complemented our appointment as acting director for the Fairbank Center of Chinese Studies. She was also previously professor of health policy at Blavatnik School of Government at the University of Oxford and senior research fellow also at the University of Oxford, and holds a PhD in economics from Massachusetts Institute of Technology. The moderators for today will be myself, Jacopo Gabbani, economist in the Global Health Unit at the World Bank, and Manon Hammerly, also an economist, health economist at the World Bank, based in Egypt currently, in the regional MENA office, Middle East and Northern Africa. With this, I leave the word to Reem for the presentation on a framework for health insurance. And thank you very much for being here again. Over to you, Reem.
Oh, thank you. Just give me a second to just put up my slides. Okay. Does the full screen show up?
Yes.
Yeah.
Thank you.
Okay. Great. So thanks, Jacopo, and thanks to IHEA for giving me the opportunity to present this work. As Jacopo mentioned previously, I was working in East Asia on countries like China, Indonesia, the Philippines, countries who have been implementing national health insurance schemes for several years and are currently carrying out what I would consider second-generation reforms. So improving the targeting of their identification systems, refining their benefit packages, their tariffs, and digitalizing their claims management systems. And so when I moved to the Middle East, North Africa, or the MENA region, which is mostly middle-income countries, I thought that the challenges would be similar as in East Asia. But I was surprised to find that the concept of health insurance and some of the essential features of what makes health insurance were missing. The main motivation for pursuing health insurance was not always to increase access or to provide financial protection, but to raise more money for the sector. And even if we provided estimates on the limited potential revenue from health insurance, given high employment, low per capita income, very large informal sectors, and in the region, very low demand for insurance, it didn't matter. Countries were forging ahead. And so rather than debating or engaging in the sort of pros and cons of social health insurance versus tax finance systems, I wanted to think about how could health insurance play a role within a more holistic approach to universal health coverage, and if there could be some guidance provided to improve the potential of health insurance, given that this is the reality on the ground. And so the framework that I'm going to talk about today is mostly developed very much drawing from the starting point of where MENA countries are. But I do hope in the discussion that we can open it up and see whether this resonates for other regions or for other countries. So this is what I'm going to be talking about today. I've already mentioned a little bit about the motivation. So increasingly, countries, not just in MENA, but also in sub-Saharan Africa, are launching on these national health insurance schemes are making these commitments, passing laws and regulations. So you have Egypt that passed its health insurance law in 2017. The King of Morocco announced in 2018 plans to establish a national health insurance scheme. Iraq passed its health insurance law in 2020, although it's still not operational. And UAE just last year made a decision to make health insurance mandatory for all residents. The countries in pink are the ones where most of the information draws from. These are the countries where we have a little bit more of an active engagement. And so these are the countries that I'm going to focus on. And the main point I want to make is that they're going down this path despite the less than promising evidence on the impact of health insurance. So yes, there's a positive impact on access to care, especially the utilization of curative care, but the evidence or the impact on financial protection is more mixed. And invariably, the studies kind of end their findings, kind of laying the blame to the diversity in the design and the implementation of health insurance and health insurance schemes. And so this was the main motivation. If the devil is in the details, then why not look at the design and implementation of health insurance in a more systematic way? And what would some of those features or characteristics to inform the evaluation of health insurance look like? So before we get started, health insurance means different things to different people. So I think it's worth taking a minute to define. And the first point of clarification that I wanted to make is that while pooling is an important feature of health insurance, it's not unique to health insurance. Government schemes also pool resources. What makes health insurance unique or different than government arrangements is that the entitlement to benefits is linked to enrollment and to individual contributions, regardless of whether they're paid by the individual or subsidized by government on behalf of the individual. And so this framework, this is the 2011 OECD System of Health Accounts. They classify the various health financing schemes mainly based on whether coverage is mandatory or not, or whether the entitlement is contributory or not. And so the second point that I wanted to make for the purposes of this presentation or this framework, when I talk about these big initiatives to move towards national health insurance, I'm not necessarily going to be using this framing because it no longer seems to fit what's emerging on the ground. Instead, when I say health insurance, I'm going to talk about some of the more universal kind of features that are needed to run a health insurance agency, regardless of whether it's voluntary, social health insurance, compulsory insurance. And so this is the sort of what the 7-point checklist that I had in mind on rapidly assessing whether countries are indeed operating an insurance scheme or whether they're continuing to do business as usual. So is there an legally independent insurance agency? Are contributions based on actuarial principles? Is there a roster of beneficiaries where you know exactly where the entitlement is linked to enrollment? Is there an explicit benefit package? Are provider payments output or activity based as opposed to under a publicly run scheme where it's traditionally input or line item based? And is there a sort of active, robust claims management system or any claims management review process that relies on well-developed insurance-specific information systems? So embarking on this journey isn't just about collecting premiums and issuing a card. There is an underlying enabling legal, organizational, institutional reforms that are needed. Now, I'd be remiss if I didn't mention two of the existing frameworks to look at health insurance that I think are the most practical and useful that I've come across. And the first is the 2012 World Bank working paper that provides a very high-level overview of some of the key design elements or policy choices that countries considering a health insurance scheme ought to consider. So, how should it be financed? Who should be included? What should be covered? What providers should participate at the network, and how should you pay and organize yourselves? And then there is the Joint Learning Network. This was part of their IT collaborative. And they really got into the granular level of detail and provided guidance on how to operationalize some of these policy schemes and rules around, the policy design choices into business processes and workflows. And so the question is, how do you get from A to B? And so the proposed framework that I'm going to be talking about today offers or tries to offer something in between to bridge the gap between these high-level policy design choices and some of the more granular business processes and workflows. And so the features listed here try to offer a sort of first layer to think through these high-level design choices in a more systematic way. The original idea was to do something like the OECD Health System Characteristics Survey, and initially there was a much longer list of features. But I think the burden when we tried to put this in practice to collect accurate and structured responses across several countries in a way that could be meaningfully synthesized was a little trickier. And so this is where we ended up for now, and happy to discuss if there's other features that are important or that should be considered. But in the interest of time, I'm just going to focus today on the ones that are highlighted in pink, because I think these are the ones that are most misunderstood or overlooked by countries who are embarking on this journey. Okay. So I'm going to spend a bit of time on this, and I wanted to start with the who does what question, because it is often the one that's most overlooked. And I particularly wanted to stress the implications to these legal arrangements, to financial management, and to purchasing arrangements. So we all know that there's many different arrangements for who the purchaser of healthcare services could be. It could be a state agency, like the Ministry of Health, or an independent insurer. But when talking about insurance, ideally the insurer, what we mean is this legally separate and autonomous institution. Now, the important thing here is that it's not just about the legal structure. The financing that is allocated through budgets directly to service providers is generally governed by very rigid public financial management laws and regulations. So there's an annual general budget law that sets a limit to expenditures, and you can't spend more than that without going back to Parliament. On the other side, let's take a public health insurer example. They operate outside of the budget, and they're meant to have more flexibility in how to use its resources. They're basically governed by the contractual arrangements between it and its impaneled network of providers. The last point on the financing that I want to make is that if the insurer is relying on large government transfers or subsidies, the payment of these subsidies remains subject to PFM arrangements and budget execution protocols. So why did I take all this time to explain and to lay this out? It's for two very important reasons that we see during the implementation of insurance. Even when they set up a separate legal entity, governments aren't always willing to redirect the substantial funds that flow through the budgets through the insurance mechanism. Maybe it requires changing the status of civil servants. In many public healthcare providers in low and middle income countries are civil servants. And so you would have to change the civil servant or the civil servant law. It might also require changing procurement laws. And so what ends up happening is that the budget mechanism still finances salaries and drugs, two of the biggest ticket expenditure items. And so the money that actually flows through the insurance mechanism is relatively small. And despite that, it's the insurance flow that ends up being responsible for most of the financial deficits or the health sector arrears, because the rules and the regulations that keep budgetary health spending in check aren't fleshed out under the insurance mechanism, which requires substantial administrative and managerial capacity. So I know that was a lot, and thanks for bearing with me on this, but I wanted to set that scene before I talk about who does what in MENA. So MENA is characterized, it's a multi-payer system. You generally have between 2 to 3 administrators or payers managing about 1 to 5 national level pools. All the pools in MENA are centralized at the national level. And usually the pools, the fragmentation is by type of member. And so you have countries like Jordan and Palestine, where the National Health Insurance Agency is a branch or a department under the Ministry of Health. Their ministries of health still fund most services through their budgets, with the insurance mechanism only paying for referrals done at non-government owned facilities. Then you have countries like Lebanon, Tunisia, Morocco, Djibouti, that have one, sometimes two, national social security funds. So these are still public entities, but they're extra budgetary. You have Egypt. Egypt's new universal health insurance scheme. They have established a national health insurance fund. And then finally, which is not listed here, you have the high-income countries like Dubai and Abu Dhabi and the UAE that have outsourced the management of their compulsory public plans to private nonprofit insurers. The main point I want to make here is that in all of these countries, you still have substantial financing being provided by the Ministry of Health for human resources and in-kind support directly to facilities. So the purchasing power and the leverage of the insurer is diminished. Okay. That was just the first feature. So the next one I wanted to talk about, and I'm not going to spend too much time on this because it's been debated to death. And instead, I wanted to, again, highlight the implementation lens and consequences of these choices. So for civil servants, there's usually already a mechanism in place to withhold contributions. Salary scales are known, and it's very easy to identify the percentage that's owed. For formal sector workers, you have to rely on reporting from firms on the number of employees that they have and on the salaries that they receive. And so the collection function is basically at the mercy of reporting compliance and the strength of the tax administration system and its enforcement capacity. For the informal sector workers, wage and tax records are not easily available, so they tend to be offered a flat fee. So even if you make participation mandatory, for all contributory paths, it's only as the capacity to enforce those contributions does the participation become mandatory. For the non-contributory path, the key implication for implementation is that it requires the capacity to identify, target, and enroll vulnerable households who are exempt from paying contributions. Okay. So per capita government subsidy. So this is what I think is one of the more important features given the substantial government financing that's needed to cover the non-contributory insured. In MENA, the government allocation for the poor is not always transferred to the health insurance fund. In some cases, it's meant to be, but there's no follow-through by central government. And this is the case in Jordan and Palestine. In others, the transfers are directly from the budget to health facilities, bypassing the insurance mechanism. The more important point is that in countries like Jordan, Tunisia, Morocco, Djibouti, and Palestine, the government subsidy is allocated on a lump sum basis, not a per capita basis. And so it's not linked to enrollment. The entitlement is kind of like a population-based or a categorical entitlement. It makes it very difficult to accurately assess coverage with implications for the financial sustainability of schemes. And so what you would think would be a very straightforward and widely available number, coverage, how many people are covered. In MENA, this is not the case because there's rarely a consolidated database of contributing and non-contributing members. Okay, taking that a little further, how do you target these exempt groups? And I didn't mention, but just to give an example, in Jordan and Palestine, there's the groups that are exempt are substantial. Over 60% are non-contributing members. So it's children over 6, adults over 60, pregnant women, people with disabilities, people who have cancer and kidney. All of these people are exempt from paying. How do you identify them? And so in MENA, it's predominantly based on categorical, but increasingly proxy means testing, which rely themselves on existing population and social registries to assess the potential eligibility of individuals and households. So there needs to be a continuous process to reflect new births, deaths, a continuous updating process, as well as the changing socioeconomic, employment, and disability status of people. And I think this is one of the benefits of what happened during COVID. With the coming digital transformation, COVID acted as a catalyst for these foundational investments in digital IDs, establishing unified registries, and the digital platforms for enrollment and payment. And I think it's perhaps one of the most impactful investments or areas to focus on to facilitate reaching universal health coverage via a national health insurance mechanism. And these are just some of the programs. They start mostly with the cash transfer programs. Just wanted to put these up there. Okay. What makes a benefit package explicit? Saying all antenatal care services is covered doesn't mean it's explicit. How many ANC visits? 4, 8. What is included in each visit? Blood work? Tetanus shot? The way I like to think about this is it's helpful to think about it from an invoicing or a claims perspective. Is there a service catalog with their associated tariffs? Is there a drug formulary? Is the catalog at the unit level of how these things are going to be billed or reimbursed? There's also other features beyond the scope of services and the populations eligible to receive these various packages. There are things like access controls, other co-payments, or annual or even lifetime limits on payment. Do certain services require pre-authorization? Can the patient go to any provider when seeking services, or are they assigned a GP? Other features that make it explicit include the provider network. Can they go to the private sector for services? Or is it just a sliver of services that aren't offered in the public sector that they can go to the private sector to seek care? And what are the conditions to access those services? And finally, the sort of quality and comfort standards. Are they entitled to private rooms? Things like that. And so in the MENA region, it's characterized by an implicit generous benefit package. It's rarely based on any kind of systematic priority setting process. At most, there will be a drug formulary or a negative list of services that are excluded. I think only Tunisia has an explicit list of services, about 54 services, where they can seek care, and it's only for services that are referred to the private sector. There's also no selective contracting. Public providers are generally automatically included, and there's no formal assessment of credentialing standards beyond checking for basic licensing. And although the private sector is allowed to participate in the network, their participation is very limited. And the last two features that I want to talk about kind of help explain why that is. So provider payment methods and the degree of provider autonomy. I think these are some of the most important features to get insight on the service delivery context in which the health insurer operates. Unfortunately, they were also the ones that we had the most trouble getting accurate inputs on. There does need to be a basic or a baseline level of understanding about the differences between provider payments. And I think the trickiest difference was, the people we had to explain is line item versus global budget. Also, what is meant by the degree of provider autonomy. But I still think it's worth including these features because they're so important to understanding the context. And in the MENA region, it's characterized predominantly by line item budgets. There's still a lot of reliance on line item budgets, but also some fee-for-service. But the fee-for-service part, the fees for insured services tend to cover only the consultation fee. As I've already mentioned, public providers are still receiving significant supply-side financing, so salaries and drugs. And because of that, the fees, even though there may be a markup for what's offered to the private sector, it's not enough. It's not attractive enough, the markup, to encourage participation in the plan. This is not to mention the delays in payment that private providers are not willing to put up with. And the last point, yes, public providers in the MENA region have very limited provider autonomy. So I think only secondary and tertiary hospitals in Morocco and Tunisia are budget holders. For the most part, it's pretty centralized. Okay, so coming back to this 7-point checklist, we find that MENA's delivery context is a lot closer to a publicly administered government scheme than to an insurance-based one. Even when there is a legally independent insurer, the bulk of the financing does not flow through it. So they're not really financially autonomous or even solvent. Most health expenditures are still funded by the government budget. There isn't a consolidated roster of members because for many, entitlement is population-based, based on broad categories without active enrollment. The packages are implicit, and there's still a strong reliance on input and line item-based budgets. And yes, the claims management process, I wouldn't call it a claims management and review process. It's more bills are being reimbursed with no selective contracting. Okay, so to wrap all of this up, so there is a whole set of enabling systemic reforms that are needed, independent of whether health insurance is pursued or not. And I think when you look at the high-performing healthcare systems, you see these common transitions from paper-based to digital information systems, from input-based financing to activity-based financing, from limited provider autonomy to increased provider autonomy, and from a patchwork of schemes and implicit benefits to universal coverage and explicit benefits. I think having these foundational investments in place helps put MENA countries in a better position to integrate their patchwork schemes. And so I wanted to think more broadly again, rather than an either or, can MENA think about a tax-financed guaranteed essential package provided by the public sector, regardless of level of income, and a mandatory health insurance package for a very limited set of services that are not available in the public sector, and then voluntary health insurance for those who can afford it. Because this is the status quo. This is their starting point, and it's a lot less of a shock to the system if you can just, the challenge is to just define the packages that are covered under each segment, as well as the populations that is eligible for government subsidies under the mandatory health insurance package. So if we can, work with the status quo, I was interested in seeing if this is just something, if this is just the landscape of what MENA countries look like, or if this resonates with other regions. And so I think that's it. So I will turn it back over to you, Jacobo.
Thank you very much, Reem. Actually, I will take over from here. First, thank you very much for your presentation and for detailing such nitty-gritty aspects of health insurance. It's very clear and a lot of food for thoughts. So we will now turn to the panel for our discussion. So they were introduced previously. We have Professor Winnie Yip. We have Professor Hasbullah Tabrani and Dr. Michael Amara. So I will first ask a very general question to all of you, and I will ask you to answer this question one by one. So it's the same for all. I wanted to ask everyone whether you, in light of the diversity in design and implementation of health insurance in LMICs, do you think that this framework that Reem presented can be used as a tool to assess the performance of health insurance scheme in one country implementing social health insurance? Do you believe this is a useful tool to go beyond the discussion of contributory versus non-contributory debate? So I will first invite Winnie to answer this question, and then we'll go to Dr. Amara. Thank you.
Great. Can you hear me? So thank you very much for inviting me to be on the panel to discuss. Reem, it's very nice to see you, and excellent work. I think what you have presented is very rich material. And I would say that to answer the question posed, I think that what you have proposed is probably not just for MENA. I would say that the questions and the aspects that you have listed would be fairly representative for any country that is trying to design and implement a health insurance scheme, right? So in that sense, I think that's the strength of the framework, because it is not specific to a particular region. I actually think, even though you make reference to MENA region, maybe it's just that looking at the MENA region, you'd give you that thought. But I would say that it is pretty generic. And in that sense, that's the strength of their framework. What I would like to suggest is a few things. The question you posed to me, Manon, is the performance of health insurance. I'm less convinced that this is a framework to look at the performance of a health insurance scheme, because for me, the performance of a health insurance scheme should be measured by to what extent it is improving access, improving equity, improving financial risk protection. And I don't think it is the purpose of this evaluation framework. I think this framework is a good framework to evaluate, or maybe it is a good framework for any country who is trying to put together an insurance scheme, a whole checklist of things that they should be thinking about that includes both design and implementation. And it is less about looking at the potential effects of its consequences. And that on its own is still very important. So I would make it clear on what is the objective of this framework. It is really to help countries to think about, here are the essential elements for you to think about if you're designing a health insurance scheme and when you are implementing an insurance scheme, and less so on a model that would be helpful in predicting the consequences of the insurance. So that's how I would classify the goal of the framework. I have a little bit, maybe we can come back to that. I have a specific question about your slide on explicit benefit package. It's a hard core to have everything to be explicit. Maternal and child health is an easy example because we know quite well what needs to be done. But once you go beyond a few health conditions, the rest of them becomes very hard to say where, what is the explicit benefit, right? So theoretically, that is nice, but I think that practically that is very hard. And also, I think what is missing in that slide is this. You seem to be implying that you're designing your benefit package from a idea of maybe what is maximizing people's health, right? So you didn't really say that countries should decide on, is it most important in maximizing health, or is it most important in financial risk protection? Because that would actually affect what is the benefit package. And what is also missing there, I think, is that in practice, the benefit package is always a result of a compromise between how much money is available. And I think that's the problem of what I have seen in the last 10, 20 years, is country make these grand announcements of saying to people that we're covering everything. But actually, there's no calculation on how much money is required to cover that. And I think we need to get it to a little bit more of a transparent situation to say, if this is the only money we can raise, then this is the benefit package. And people should understand that if they want a bigger benefit package, then they might need to contribute more. And I think that's a missing piece that if you can incorporate, that would be very helpful. Then and then I'll shut up. I also want to comment your last diagram. I do think that last diagram is pretty generic, right? I mean, we would like to eventually go to a stage of which we say that some standard of uniform benefit package of which everyone in the country, irrespective of income level, should be entitled to. And for equity reason, they most likely will be funded by, ideally in LMIC, general tax revenue. And that's hard. The question, the difficulty is, where do you draw that line? Then on top of that, you lay on top of that a little bit more of contribution. That's fine. That's dependent on how much money is available. And then for the richest one, they can even buy some private insurance as well. And so I think what you have laid out is a very good framework. And actually, that's what I've been telling countries. The hard part is for low and middle income countries, the basic bit, I mean, where do you draw it? You can use what WHO, World Bank has been defining, the essential package for UHC, but to what extent that is reflecting people's interest, people's needs. That I think is the biggest question, because sometimes people are so used to getting the things that they have been getting, and then when you have that essential benefit package drawn at a level that is not reflecting people's need, what happens is that people go to private sector and spend a lot of money, and that's the major source of catastrophic health expenditure. So once again, I think this is going to be really helpful for any country thinking about designing and implementing a health insurance scheme. Over to the next panelist.
Thank you very much, Winnie. Dr. Amara, can you please come in, and then I will ask Prof. Hasbullah. Dr. Amara, can you hear us? Okay, so maybe...
Hello.
Yes.
Yeah.
Yes, please.
Good morning. Thank you very much. I want to honestly say thank you very much to our colleagues for that wonderful presentation. A very comprehensive one. For me, I believe this is a very good framework, not only for designing social health insurance, but also to evaluate the performance of social health insurance in any given country, especially for low and middle income countries. For me, I see this as a very good tool for countries like my country that is about to implement health insurance in our country. So I want to comment that it's a good framework. Countries can use it. It is a generic framework that countries can use and then do their own specifics. With respect, one of the components of the framework which I really consider great is a benefit package. I mean, countries design benefit package based on their country specific. As my professor said, I mean, there is no one country that can take 100% benefit package. So because it's bears cost implication. So before you think about the benefit package, you have to think about how much that benefit package will cost you. Because that is going to be during the implementation of the scheme. That is your menu that people will want to see. If I join this scheme, what will be the benefits that I will get out of this scheme? So countries can use this framework to design their specific health insurance. So for me, I think it's a good framework, and which I believe countries can leverage on, and they can use it to develop their own scheme and also to evaluate those existing schemes across the globe. They can use some of the elements to evaluate whether they are performing very well or not. They can even use it to check whether they are improving on their health indicators, like, for instance, the maternal mortality rates that Professor mentioned, the infant mortality rate. I mean, those critical health indicators, they can use it to evaluate. And above it all, the issue of equity, the issue of efficient use of resources for the implementation of the scheme. So in summary, I think it's a very good framework, and I want to say thank you very much. Countries can leverage on that and then design or evaluate the performance of their schemes in existence. Thank you.
Thank you, Dr. Amara. Prof. Hasbullah, over to you.
Thank you, Manon. It's good to see you again. Yeah, hope to see you all in Bali next July for IHEA conference. Yes, thank you, Reem, for the presentation. It's a great presentation on this technical know-how, how to protect people from financial catastrophic when they need medical care or health care. However, I think when you use the term insurance, these terms in many, well, at least in Indonesia before, it's understood as separate from the government tax-funded system as NHS. They consider the insurance mechanism is different one, either commercial or social. But I like the ideas of making the term insurance as a way of pulling some money, tax funded or non-tax funded. It is a general understanding of the insuring people to get healthcare. Basically, that's the means of this. Yeah, certainly different country has different condition, economically, culturally, and also politically. I think this framework is good to be used when or where there are perceived needs of financial protection. Often in low income countries, experience Indonesia when we were in the low income countries, people don't think that the need for a health protection. They're still struggling for the tangible basic need, food, clothes and housing. They don't really care about that. In that situation, certainly it's more difficult to mobilize the insurance model, which contributory, but non-contributory as funded by the government certainly apply. However, with the low income condition, the government ability to finance, to subsidize or to provide with direct fund channeling, traditional rigid public finance modeling also produce perceived low quality. And therefore, I think this framework can be used when we have a relatively high perceived need and the political will to have financial protection. As Professor Yip mentioning, people often push to private provider because in the insurance of the public funding perceived inadequate or the quality poor. So insurance model with the traditional concept of transferring some risk by paying contribution or premiums can be used as a top up, as you draw in the graph in the last slide. It's top up for certain group first as a transition model for a higher income who have some perceived need for the financial protection. I think I stop there, Melan. Thank you.
Thank you very much. So we'll go with the one more round of question to the panelists, but just in the meantime, I want to invite everyone to ask questions in the chat for the discussion later. Hopefully we'll leave enough time for the question from the audience. So I will start with the Professor Winnie Yip, because I know you have to leave earlier. So we wanted to ask you that in light of the debates and the various publications, against the case of health insurance, we wanted to hear from you what practical advice can be, given in a country that has already implemented social health insurance. We find that in places where it's already in place, what are the pragmatic recommendations that we can start first? So you mentioned the benefits package and making sure that it's within the budget envelope, but what would be for you the key priorities in terms of recommendation in a country that has already some sort of laws around social health insurance?
If you ask me that to say one thing, there are many. I think if you look at the literature that has been reviewed, including Jishnu's paper, and that I think that a missing piece is the last point that Reem was saying. A lot of times, social health insurance is being designed, being thought of as a resource mobilizing mechanism, but without thinking that it really have to design its provider payment correctly. And I think we have now so much evidence that when you expand insurance, but without appropriate provider payment method, quite often it leads to sometimes even worse outcome. Or if you develop social health insurance without knowing that there is enough supply in certain places, then essentially it's just you're having insurance in name. You're not giving people access. So I think that my worry about many countries doing insurance is thinking of it as a pure financing mechanism, but without thinking about the financing mechanism is only a tool to get people to have access to care, quality care, and therefore the linkage between financing and the delivery side very often is actually not pay enough attention to. And I also notice a lot of countries, they would say that that's step 2. I'm just going to deal with the financing first, then I'm going to deal with the provider side. And quite often it doesn't help that way, because once you start implementing insurance, provider have developed a certain behavior that is actually very hard to change them. So I would say that I think the countries that, I mean, Reem, you have cited, is doing provider payment change, but even then, many of them start at a very small scale and slowly expanding. And for many other countries, the provider payment change part is actually not an essential part of it. And if you look at the paper that Jishnu reviewed, actually the evidence that he reviewed was also using a lot of data during the time that when insurance was established without much provider payment change. And I do think that is a critical point. And since I talk about provider payment change, I have to use this opportunity to say one thing that I always say to countries. I think every country, 90% of the country in the world are trying to implement DRGs for inpatient services. I am not convinced that's the right way to go. Because one, DRG requires so much data. Most low and middle income countries just do not have that data. Number 2, DRG was developed in the United States 30, 40 years ago to deal with acute care. And meanwhile, we're all saying that we want to be having a delivery system that is more population-based focus, primary care-based focus. DRG is just creating an incentive that go against that. And I still find it a little bit irrational, and for me, it's sometimes a little bit unacceptable that we think all LMIC need to go through the same stage that the United States has gone through for the 35 years, and then now come to try to do bundle care, whatever. But then now the hospitals are not very happy for you to try to bundle their care. So this is my plea. And the other thing that I would say that, you know, that explicit benefit package is actually sometimes quite hard. And in fact, a lot of times what we have seen, and I'm not familiar with MENA region, what we have seen around the world is that there's a tendency to think that insurance is, one of the goals for insurance is to provide financial risk protection. And there's a certain belief that the cause of catastrophic expenditure is hospital care. Therefore, in the last 20 years, we have seen a lot of health insurance covering inpatient care generously. And that is just wrong. Because a lot of source of catastrophic expenditure is actually repeated outpatient visits and for buying drugs in the private sector. So if I would urge is that help countries to say that when you think about an insurance, don't think of it as just a financing mechanism. It is a tool to impact some larger system outcome. And therefore, the question is, when you design your health insurance scheme, how do you use that financial power to leverage delivery system change? And so strategic purchasing, provided payment, of course, some of them. And I would even add to say that, do you want to do some selective contracting as well? Right, Reem said that most of the public provider by definition are already included. I don't see why by definition they should be. It's more of a political economy problem. Because you should really be contracting the one that is actually providing good service. You should be using financing to incentivize providers who would normally not go to rural area to go to rural area. And I think without the service part, people still don't get care.
Thank you very much, Winnie, for those very good points. Maybe I just have one follow-up question for you. So you mentioned the importance of provider payment mechanisms, and I think that's really relating to one of Reem's points in the presentation, right, that providers need to have more autonomy as well. And from your experience, do you feel that what's preventing countries to improve those provider payment mechanisms? Do you think it's related to public financial management issues or rigidities in the way the budget is set up? That seems to be a major constraint as well.
Yes, I think everything that you have said are
You're muted, Winnie, sorry.
I think everything that you have said is absolutely true, because countries are so used to line item budget, and therefore it's very difficult to change that mindset. The autonomy, what Reem has pointed out, is precisely a major barrier for provider payment to have an effect. If they do not have the autonomy to think about how they use their input, right? I mean, the whole idea of provider payment is to say that you give the provider the incentive, and then they would be choosing the right thing to do. But if they don't have the autonomy, they can't be choosing the right thing to do. But my experience is also that that is a hard part to introduce in many country reform, because a lot of public hospitals is part of a big civil servant apparatus. You're basically telling the country that you need to take the public hospitals and treat them differently. And sometimes it just doesn't go very well, including that, do you allow the public hospitals to say, in order to improve efficiency, I'm going to reward my physicians whose high performance with higher salary. And when you're stuck with civil servant pay, the hospital manager practically do not have that as a management tool. So you think about hospitals that are typical public hospitals, and if you think about what is in the hand of the hospital director as a management tool to get his physicians to do the right thing in order to respond to provider payment change, there are not that many.
Thank you very much, Winnie. I will now turn to Dr. Amara. We wanted to ask you, so in the case of Sierra Leone, there is a substantial challenge with regard to the informal sector that is very large in this country. So we wanted to know from you how this particular feature of Sierra Leone, but also elsewhere, has impacted the design and the planning of social health insurance in your country. How was this factored into account in the design and implementation?
Thank you very much for giving me the platform and another opportunity. It's a very interesting question. I will want to start by saying, I mean, as you rightly mentioned, we have a huge number of informal sector in our country. Precisely, we have 95% informal, 95% of the population that are informal sector. And so therefore, in our process of designing our own scheme, That is very critical, and we are very mindful of that. As an impact to the design, it's the issue of how do we identify the informal sector, and then how do we classify the informal sector. In the sense that we believe in the informal sector, we have people who have the ability to pay, and then we have people who do not have the ability to pay. And so how do we play around that in our designing, that it will not really create a bigger impact in the implementation? So we took that into account, and we believe that if we fail to design it very well, if we fail to identify those informal sector and then classify them into various groups, as I have mentioned, that we have those that have the ability to pay and those that do not have the ability to pay. And so that is very fundamental in the design of our scale. And I believe in the informal sector, we are also fully aware that we have a structured informal sector in our country, which we believe if we design the scheme in a very appropriate way, we'll be able to implement the scheme at the end of the day. Added to that, we are of the opinion that in terms of contribution, that's also critical for us in the formal sector. Because when we did the willingness to pay study that guided us all to start putting the design in place, it came out clearly that the informal sector is willing to pay a sum of $2 per person. Cumulatively, if you put that together for 12 months, that's a little bit of money. But how do we motivate, or how do we sensitize the people? How do we educate the informal sector to be paying this contribution? And so we took all this into account, that public awareness of the informal sector is very critical in the design, to make sure that when we come up with a good design for our country, the informal sector must be fully aware of the package that we are coming up with. That's why in designing the benefit package, we are also very mindful about the informal sector. So by and large, the informal sector is very critical to the design. And because of we are getting a lot of challenges in terms of identifying and classifying those informal sector, that is one of the factor that is impacting on the design and even in the planning of the scheme. But we have reached to the level where we believe, after looking at all the parameters and all the elements attached to the informal sector, we are now trying to put a better, well-designed, well-structured insurance scheme for our country. So the issue of, as I mentioned, the issue also of their contribution. We did the financial modeling just to get a feeling, when we put those numbers together, how much it will cost us per annum. So when we did our financial modeling, we realized that nothing much is coming from the informal sector, even though we have 97% of the population that fall within the informal sector. So that triggered us in our designing to look out for potential funding sources that can really make the implementation of the scheme very successful in a more efficient and effective manner. Because it's not just a matter of implementing insurance scheme, but you have to have in mind that this insurance must be sustained. Sustainability as an issue is very critical for us. And also, how do we use the resources in the most efficient manner? So these are all parameters that we really consider. We are considering to make sure that at the end of the day, when we come out with a more credible design scheme, we should be in a position to manage it very well, so that at the end of the day, we'll be able to deliver the quality healthcare services for our people, for the Israeli people in our country. Because our target is we want to achieve the universal health coverage, which is very critical. And we want to make sure that everybody in Israel gets access to quality healthcare services. So having in mind the informal sector domain, it is very critical, and it is impacting in the designing and planning of our scheme. Thank you, over.
Thank you very much, Dr. Amara. I have two additional questions for you. So you mentioned I understand you've conducted some willingness to pay study to understand how much people are willing to contribute. And there were I guess, campaigns, or I don't know, any other tools to ensure that everyone is aware of their benefits. I'm just wondering, practically speaking, how will you differentiate those who have the ability to pay? How in practice you can target them? What tool can you use to ensure that, you know, people would be targeted into those who can contribute and those who cannot contribute? And also you mentioned other sources of financing. I'm just wondering what this would be.
Thank you very much for those two questions. I mean, in the process of designing and planning for the scheme, we have structures in our country. There is an institution that's charged with the responsibility to identify and register the vulnerable population within the informal sector. So we are working with them closely, and that is the institution. We call it the National Commission for Social Action. That is the department that is charged with the responsibility to come out clear with a credible list that can show us that these are the vulnerable population in the formal sector. And then for the remaining part of the formal sector, we can easily manage them by having those structured informal sector that are in employment, whether self-employment and the like of that. So yes, we are using and we are leveraging on the expertise of this department to give us a credible information that we can easily differentiate who have the ability to pay and who doesn't have the ability to pay. So that's the way we can differentiate the ability to pay and the non-ability to pay. And the issue of resources, as I said, when we did the willingness to pay, it came out clearly that people are willing to pay a sum of 15 loans, as I said. Cumulatively, when you put that together, it's about 180 loans. When you change that into dollars, about $7 to $8 per annum. That means our people in our country, they are willing to pay for the scale. And that's why in designing our benefit package, we are very mindful to ensure that we don't come up with a very ambitious benefit package, but a benefit package that will be affordable to the people of our country, because we are very mindful about the socio-economic status of our people and even the micro-physical space of our country. And so we are mindful of that. That's why our benefit package is not very, very, very ambitious. It's something that is going to be affordable to the people of this country. And I believe with that, we were able to identify another potential funding sources by leveraging on the tax payment, tax revenue, which we have tabled that severally to the Ministry of Finance to ensure that whatever taxes we identify, the Ministry of Finance must be aware, and they should work together with us to make sure that we are able to tap into those resources so that when we start the implementation of the scheme, it must be sustainable, not a matter of implementing a year or two and then it die down. We want it to be sustainable, and that's why we're very mindful in the designing and planning of the scheme. Over, thank you.
Thank you very much. I will now turn to Prof. Hasbullah Tabrani as the last speaker of the panel. So you have been supporting the development of health insurance in Indonesia in different capacities since its very beginning, and in particular towards the implementation of the JKN scheme, which consolidated all previous scheme and more than 300 risk pool, the national and local level, with under one national pool, one uniform benefits package, and one single purchaser of health services. So we wanted to ask you, how did Indonesia do this, given the variety of premium contribution, benefits, payment methods, tariff that were pre-existing in the pre-existing pools, and what is required from political and administrative capacity to reach that success?
Yeah, okay. First of all, I think I would like to explain first that the concept of health insurance require perceived high risk or perceived financial high risk if they don't have insurance, and that related to the existing condition of the countries where if the public sector providing low price, low quality healthcare in the public sector and no private healthcare providers that provide different higher quality, higher price, and people can see what the benefit, there will not be a development of the demand for health insurance. That's the situation that Indonesia facing in 70s and 80s. So we have long battles about how to make sure that everyone gets healthcare when they need it, regardless of the provider's type, public or private. We debated about the public financing model, tax funded, or commercial insurance, or social insurance, or many other voucher model for quite a long time, 20 years, more than that. That's kind of the maturity needed to make people understand what is it and why, and so on. At the beginning, even the term insurance is kind of, in Islamic law, they call it haram, because it is kind of not acceptable by the people. It took almost 10 years to make the people understand what is it. Then we have also some advantage. We already have the social insurance model for civil servants for 30 years when I wrote the law for the national insurance at the time in 2001, 2002. And also we already have expansion of social insurance for private employees, that people compare the two different schemes, and also the social assistance program or subsidized by the government, with a different quality, different access, different way of providing, and create some kind of jealousy or criticism of equity issue that then create demand to unify the scheme. Yeah. So that's kind of process is that we undergone for quite a long time. And then we have also blessing in disguise, I would say blessing in disguise, because in the late 90s, Indonesia, as also some other ASEAN countries, suffering from severe financial crisis that sparked all the demand for reform of the public sector, private sector, education, health, and so on. So we took that opportunity. We have a lesson from previous 30 years, applying the HMO model of the commercial insurance model of the US with the managed care technique in paying the providers, which is turned to be efficient. And also we already apply also the DRG. For us, we use that one. So we have that experience, we pull the experience, and we have also supported by the demand, high demand for overall reform to unify, to make sure that everyone get healthcare they need, with the equity issue, no discrimination, and so on. So we have that kind of public sector and political will from many political parties that supporting our design. Certainly, then we design taking some advantage that we have done before. So that's kind of different cases for Indonesia. But in general, we have to have people with relatively ability to pay. If the people per capita income, some studies showing that per capita income below $2,000, that might be difficult to introduce insurance. But insurance is a good option to expand coverage, to improve quality gradually for countries where tax ratio is low, where the public sector do not provide quality of care that people already have demand for better quality. So that's gradually. We cannot just expand everything nationwide. I think that's very difficult for countries to do it in LMIC. I think I stop there, Manon. If there is some, under the administration, we learned from previous system where the government at that time, the Minister of Health administered the system, and this system didn't develop because the public finance management system did not provide incentive for the administrator to do the good job. So we use the independent, specially established, what we call it, public entities. It is parastatal. It is not corporation or company owned by some people. It is the public one, like government, but separate from the government. So it is not using the government payroll system, for example. We manage this as private entities to have the autonomies, and we transform also public hospital, public health center into a quasi private entity, what we call it autonomous hospital. We call it BLU or public service organization, which has autonomous, exempted from the public financial management that's rigidly for other sector. By doing that, we put the healthcare providers and the insurance administrators, both independent, can negotiate, contracting, and so on, to incentivize good quality. We apply the credentialing process to ensure that only certain qualified healthcare providers can be contracted by the National Health Insurance. But there's all of those take some evolutionary process. Over.
Thank you very much, Prof. It's very interesting to hear that in Indonesia it seems to be the result of building blocks set up over decades. I think we have a few minutes left for the Q&A, so I will pass over to Jacopo, who's been monitoring the chat.
Yeah, we have a good number of questions, which is great. I see that Reem is already answering and some of the discussion is happening in the chat. I'll actually, one question that came up twice is a follow-up on Winnie's comment that DRGs in many cases are not appropriate, and I guess that the question that came after that was which provider payment might be more appropriate then. I realize that obviously in every country and depending on the objective of each country, a different provider payment mechanism, different add-on, different details in the provider mechanism could be thought through, but I still wanted to ask this to our panelists, and maybe I'll start with Reem also to give you an opportunity if you want to start before answering the question or reflecting on the question. If you have any reflections on the comments provided to the framework, which I realize you didn't have a chance to respond or not respond, but reflect. Over.
No, thank you. I'll start with the last question that you just asked. I think if you look at the textbook literature, you often see that, this recommendation that, the most efficient way of paying providers is capitation for primary healthcare, DRGs for hospitals. But I fully agree with Winnie that, the level of complexity and the administrative capacity and the data that's required for different payment methods doesn't facilitate, and in some cases worsens the situation. So I do think it really is dependent on your starting point and what systems and monitoring and data collection you already have in place to be able to give a specific country-specific response. On the broader questions, I did want to get a chance to respond to Winnie, but I think she's already signed off. But just to say that, I mean, I fully agree with her that the framework is more of a sort of for implementation design. I think initially when I thought about this, I did want to try and find features that I could quantify, categorical dummy variables, things that I could eventually plug into a model to see whether there were some patterns. But the quantifiable features were few and far between and hard to get in a substantive number of countries. So it kind of evolved, and this is why I'm really grateful to Manon and this working group of practitioners to kind of brainstorm on how to repackage or re-envision the usefulness of this framework. And so I'm going to follow up with her offline on that. The only other thing I wanted to mention from her comments on the explicit benefit package, I fully agree. I think, and this is why in the context of MENA, since most of the services are already delivered through, budget, the idea for focusing on a very limited set of services and to define the explicit nature of those services. So it's not an overwhelming task. Like in Tunisia, it's like 50 or so services that they've defined. So to think about that more limited set, and on the features of how you do that prioritization and the resource envelope, those are actually features that I have and that I've considered in an earlier iteration. And based on that comment, I think I'll reintroduce on what are the criteria to expand the thinking around the design of an explicit benefit package. So those points are well taken. So I'll stop there. Over.
Thanks very much. And yeah, I might also follow up with you and Winnie on this for other work that is happening in the Global Health Unit on health insurance. There is another question. This one comes from Mr. Moses Friday from Uganda. And he's asking to share how to ease the enrollment of the informal sector. I think that there's also in the question how to cater for those not able to pay the premiums. I think that has been at least in part discussed by Dr. Amara with the identification through a separate authority in the government that already identifies vulnerable groups. But I wonder whether there is any additional comments from Professor Tabrani and Dr. Amara on easing the enrollment or facilitating enrollment of the informal sector. Professor Tabrani, you might want to start.
Yes, I can do it. First of all, I would like to comment a little bit about the payment system. If we look at the literature, everything, the payment system with prospective payment is the best way to do it. But prospective payment, not only capitation and DRG. Since the root of this payment system is the very high asymmetric of information between the providers and their patient. Without the risk-based payment system to healthcare providers, the scheme will be very, very high risk of a lot of moral hazard and fraudulent. And therefore, we have to find that one. But to do that, yes, we need a good information system. Without good information system, we will not be able to estimate how good it is. In Indonesia, we have all nationwide claim system linking all the healthcare providers, and we collect their price, and also we develop from that with a lot of work on developing the average cost for different CBG, different level of the risk of the people for the capitation. For the going to the informal sector, I think the first system should be good enough to cover the formal sector first, which is easier. It's not because they have a higher risk. It is easier to manage. Once we have got trust to manage the formal sector, then we can expand to the informal sector. Otherwise, we will have problem of adverse selection of the informal sector. We cannot enforce them. We cannot detect their historical healthcare consumption or health risk. It will be a very highly likely, as in commercial insurance or voluntary insurance, that the higher risk will enroll first. And if we do have that one, certainly for just a couple years, the system will bankrupt because of the insolvency. So I would recommend start pooling the profile at the formal sector first, because that's easier to mandate the employer to contribute, and it's linked with other regulatory system to take out license and so on. So the compliance rate will be high. Indonesia, the compliance rate for formal sector 99.9% collection, but the informal sector, we have only about 50% compliance rate to contribute. Also difficult to assess, if we do social insurance, difficult to assess the income level, which based for the contribution. The social insurance scheme is supported by mandatory contribution proportion to the income. That's the difficulties. So we have to be realistic. We start with the manageable scheme first. That's my comment. Thank you.
Thank you very much, Jacobo, for that interesting question. For the informal sector, we in our country, we have structured unionized institutions or entities that we really want to use in terms of enrollment of the informal sector. I mean, informal sector, as you are aware, that domain is very critical, as you have heard from Prof. I mean, when you start with formal sector, that one is very easy. The formal sector domain is easier to manage. But for us, we believe the way we can get the informal sector to comply is that we want to leverage on those entities that I mentioned, the unionized entities. We can use that opportunity, that window of opportunity, to get the informal sector on board in terms of compliance, because the scheme which we are about is going to be a mandatory scheme. There is an act that's is giving us the mandate to implement the scheme, and so therefore we believe by using those structures, those existing structures in our country, we'll be able to get the informal sector on board in terms of enrollment. And that means, what that means, I mean, definitely the compliance rates of the informal sector will be realized and will or must be on a higher rate. So that is what we have in mind, and that's the way we want to go. I mean, until we test it, and then we can start seeing those challenges, and then we must find solutions to mitigate those challenges. But that's the way we want to leverage and move on with regards to the informal sector enrollment to the scheme. Thank you. Over.
Amara. Reem?
No, I just wanted to come in because this compliance rate was actually one of the aspirational quantifiable features that I wanted to include. And specifically for the MENA region, this information is not readily available. So we used proxies of contribution to social insurance more broadly. And I think what's really important is that, unlike in Indonesia, where formal sector compliance is quite high, in the MENA region, it's much lower. I thought that maybe we could get some kind of global estimates, but this is really something that needs to be looked at region or country by country, that's dependent on the tax administration policies. So it's like 65% only 65% in Morocco or in Egypt, I believe, and like 41%. They're much lower, even for formal sector workers, because the compliance is not high. And for the informal sector, it's less than 1% compliance. So this is actually something I would love to institutionalize and start collecting information on, because it'll really kind of move the needle on tracking the sustainability of these schemes. So I just wanted to say that very quick point. Over.
Great, thanks, Reem. Maybe one quick comment from me on the provider payment that we had a discussion on this very recently, was also that there might be, in large countries that have decentralized administrations, there might be even different provider payment schemes at different levels. So from the federal level to a region or a district, and then from the district to the provider, which also the different level across the administration of organization of a country can play an important role. Great, we're at time. We are 1 minute late. I would like to thank all the panelists and all the attendees for many questions, and I see that we're still almost 50 in the room. I believe the feedback was very positive on the framework, with some thoughtful remarks for consideration. So thanks again for the great discussion, and have a good day ahead.
Thank you. Hope to see you in Bali next year for the IHEA conference.
Indeed.
Thank you, everyone, and thank you, Reem, for the presentation. We'll send the presentation to the participants.
Okay, thank you very much. I was going to ask you for the presentation.
Thank you so much.
Thank you very much. Thank you, Jacobo. Thank you. Thank you.
Thanks, everyone. Bye-bye.